In this lecture, would like to first to thanks my colleagues who asked for this lecture to be in English. I think it's very obvious that my English is not good enough for strong lectures like this, because these are lectures where we are discussing things and trying to simplify things. It's not a formal type of educational teaching, but I will do my best to improve my English, but forgive me if my grammar is awful. My accent has no meaning. My first language is mother tongue language is Arabic, and so you feel more comfortable doing it. Although most of the medical terms are in English. My second language was French as well, so you can imagine that my accent is really awful. But if you forgive me on that, then I'm happy to try my best to keep all lecture in English, or maybe I can switch between English and Arabic as much as I can if I have enough time for that. So this lecture is for my junior colleagues, and please, all seniors, relax and stay away. This week is not for you; it's for my junior colleagues. We will go through the how to delineate the organs at risk. It's clear that the guidelines are there. You can go through it. So I want you to try to go together. And so if you open your planning system now and like select any head and neck case, and we go together step by step, I think this will be the most this is you get the best out of it, and then you can make it as a practical type of thing rather than just a lecture. So if you open your planning system and try to do step by step what I'm telling you, this may save time for you reading the guidelines, number one. Number two, you can may help you to understand what the guidelines is telling you and how they created it, maybe a bit. But as I said, this is a very simple, easy lecture for the seniors, so the seniors can relax this week, and we will see them again later on. Okay, good. So let's open the planning system and let's go to the risk structures in our planning system. So let's delete list structure. We want to delete them. I think we'll delete the hypothalamus, optic nerve, chiasm, because we need to draw it together, and we delete it. And then maybe the cochlea as well, can delete it, and then we go through them together. Okay, good. Let's go for the axial view. Good. Open your planning system now, and let's go to the axial view, and let's see if what kind of risk structure we can draw in brain tumors or in head and neck cancer patients. So let's go up in the brain and let's see what we can do. So as any planning system, any structures in any brain or head and neck, I would suggest, yeah, you have to draw the eyes. We don't have to spend time looking at the eyes and drawing it. This is make no sense. Maybe I just want to make sure that when you draw the retina, make sure that you're taking it from the ciliary body or the level of the lens all through, but you don't go anterior. But when you go up, you will have to draw the retina all through, which is, I mean, covering the underneath the sclera. So this will be the whole circle will be as a retina. I would suggest that you draw the retina in any sigmoid tumor, and be careful while drawing it, because it's very important to draw it carefully. Any millimeter can make a difference in a very narrow area like this with the isthmoid cancer patients. The second structure is the optic nerve. I think we went through the optic nerve before. We don't have to do that again. All what you have to do, or quickly, because we said it's just for the juniors, quickly you have to go to the eye. So if you go to the eye, down the eye is small. If you go up, the eye is small. Go to the slice where the eye is the largest, so you can see the diameter of the eye is the largest. Look posterior to it. This will be the optic nerve. It's not common, by the way, that the optic nerve will be complete like that. I will just have to draw the optic nerve because it will be useful to have at least one. It's not common to to have a complete optic nerve like that. Sometimes it appears as a small piece, and then the second cut downward, and medially it will be here. So we all know that the optic nerve is directed medially and downward. I will draw it inside the canal, and we talked about it before. We have to separate between the optic canal and the anterior clinoid. This is anterior clinoid, the optic canal, and the nerve going inside the optic nerve. Please make sure that you draw it inside the optic canal. This will be very useful when you try to join it with your optic chiasm. I think the optic nerve is very easy. You don't have to worry about it, but just make sure that you will do. I think most of the planning system now is doing this automatically, thanks for the auto segmentation, and you have a beautifully drawn risk structure with planning system like RayStation, Eclipse can do it automatically. You just have to look at it and make sure that it's correct, and that's it. But most of the planning system is doing it automatically. I do believe in few years we will not have to draw any tumor or any target volume at all. This will be automatically drawn. And if you are a junior and you are thinking about doing a project or doing a research in your future, I would say that the next coming era of radiation oncology will be what we are calling it the artificial intelligence. If you are a physicist or a doctor, you want to work on that, I think artificial intelligence is coming. So now we have artificial intelligence that can read an MRI or CT and give you a report without any kind of just maybe revision with the radiologist. I do believe that at a certain point we will have an artificial intelligent computer that they will draw for us the target volume even better than us, and we'll just have to maybe modify it, and we don't have to spend ages doing risk structures or drawing the target volume anymore. So artificial intelligence is coming, and please think about it if you think about a new project to do. And then let's talk about the second important structure, which is the optic chiasm. The optic chiasm, if you do it in the MRI, I don't have to explain it and I don't have to tell you how to draw it. But the problem is we are facing in our country, in also maybe in developing countries, if someone from a developing country is listening to me now, for those who are drawing it on the MRI and you don't want to draw it on the CT, you just skip this few, maybe 5 or 10 minutes, and then go directly to the next step, which will be the hypothalamus. But for those who are drawing it on the CT scan like me, without an MRI, you have to familiarize yourself with what we're calling it the circle of Willis. And I just have to refer to my mentor here, Frank Lohr, who taught me this long time ago, and I'm using it till now. And I think most of my colleagues are using it in our center now. And it's the easiest way to familiarize yourself and to draw the optic chiasm just by familiarize yourself with the circle of Willis. We all know that the circle of Willis is a network of vessels, and it is composed of the middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. If you remember with me that the internal carotid, after doing the siphon S-shape course, it will give us two important vessels. One is called the middle cerebral artery, and the second is called the anterior cerebral artery, and you have to familiarize yourself with that. The posterior cerebral artery will come from a very nice vessel here in front of the pons called the basilar artery. So the spinal vessels will come together to do the basilar artery. The basilar artery will divide into the posterior cerebral artery. So the circle of Willis is composed of the middle cerebral artery, which is the most important branch for our drawing the chiasm. Posterior cerebral artery, I don't care about it much. Anterior cerebral artery, it's important to familiarize yourself with it as well. Anterior cerebral artery, sorry. Middle cerebral artery is the most important one for us to draw in the chiasm, because the middle cerebral artery will go through a fissure called the Sylvian fissure. We know that this Sylvian fissure is a fissure between the temporal lobe and the frontal lobe. and this is the largest fissure in the brain. If you look at it from, as we are looking at it, we say it's the mustache sign of the brain. We look at it as if there is a mustache for the brain. And here, for example, I'll show it to you. So I'm calling it the smiling face. So this is the cistern, and this is a smiling face for the brain. I don't know if you will accept that. So this is a smiling face of the brain, and here is a mustache for the brain as well. I mean, it's just for fun, but you don't have to do that. So the mustache sign, or the mustache of the brain, we call it the middle cerebral artery. The middle cerebral artery will direct you to the optic chiasm. How can this happen? Let's see. If you see the middle cerebral artery here, the structure in between the middle cerebral artery is nothing but the body of the optic chiasm. So I can draw it easily, and I'm 100% sure that the optic chiasm will be there. So this is, I mean, this is a very easy way, and we did hundreds of cases where we fused the MRI and the CT, we draw it on the CT, and the difference is really, really negligible. And if you want to be wider, and if also you take the PRV in front, around it, I would say you will be 100% sure that the optic chiasm body will be in this particular area. There may be a bit of variation, part of the optic chiasm appearing with the optic tract, and you have to take both. There is no problem. And if you did it something like that, like for this guy, I would say it's thick, so I wouldn't do that. But if you are worried and you want to do it, I wouldn't care if you take the PRV, and that's it. All what you have to do now is to understand the anatomy, how the anatomy will look like. So if you put the cursor on the body and you move your arrow down, so we are going to the next slice, which is downward. The optic chiasm is not lying flat in the brain. So if we looked at the sagittal view, and I'll show it to you now, we're saying that we will see that the optic chiasm is not flat on the supracellular system. It's not horizontal. It's not horizontal. It's lying. It's moved, or it is directed. If you look at it backward and upward, or from the body, it will be also downwards and forward to join the optic nerve. So it's either downward and forward to join the optic nerve, or it's upward and backward to join the optic tract. So if you put your body here inside the middle of the body, and you push your button with the arrow downward, you can easily, in front of the body, in front of your cursor, you can easily delineate a part of the optic chiasm even without seeing it. So this is part of the optic chiasm. How did you know that? It's anatomy. It's anatomy. We know that the optic chiasm, when the body is there, it will be downward. When you go down, you will find it anterior and below. So if you put the cursor there, anterior and below, this will be the part of the optic chiasm. But you cannot leave the optic chiasm there. You have to join the optic chiasm with the optic nerve, as I just mentioned before. So when you go downward again, you have to join the optic chiasm. It's either you do it like that, where you extend your optic nerve inside the canal, like that, on either side will be on the opposite side, and then, or you can also do it like without the middle part of it, but we used to do it like that just in case part of the optic chiasm is still there. We are 100% sure that we are covering it properly. So let's look at it again. So the body, how did you know the body? From the middle cerebral artery. Put your cursor there, push the button, the arrow downward, then you draw the first slice, go downward, the second slice, and the second slice should join the optic nerve. You don't have to see joining it in the axial view. You will see joining it in the sagittal view, and I'll go now to the sagittal view and show it to you, but just give me a second now. So go back to the body, and then you need to also draw the upward extension. The upward extension of the optic chiasm will be the optic tract. So if I'm expecting the next cut, if you push the arrow up, going up, it will be the area just posterior to the cursor, which is, so if the cursor is there, this will be the optic tract. And this is easily also seen as like, you can say like a, what you call it, like an ear on either side. So this is the optic tract. So if you put here the body, go up with the arrow up, this is the optic tract. I'm sure about it, and I'm drawing it. Sometimes you see the optic tract in two cuts, which is fine. I can do that, but just don't join in the middle, because we know that the optic tract should not be joined in the middle, because all the optic tract will go on either side, and will be the optic tract, and that's it. You don't have to worry about. So now we draw the optic chiasm. We want to make sure that we draw it in the right direction. Let's go to the sagittal view and see how it looks like. Just open it and see here it's poly. You can see it here. Let's look what we did. Okay. If we see a structure that is lying not flat, not horizontal, and it is directed upward and posteriorly, so I think we are in the right direction. And maybe you missed a bit of part of tissue here, you just can go back and draw it, but at least we know from the shape how it looks like, and this is the optic chiasm, and we are drawing it in the right area and the right region. Maybe you need to just extend it. Just to make it thicker. Sorry. One of the landmarks as well to help us in the optic chiasm is the infundibulum. You have to keep the optic chiasm. Sorry, it's a bit slow. You have to keep the optic chiasm anterior to the infundibulum. So if you go up there, if you go up to the brain tissue, okay, you can see a white dot here. Yeah, you can see this. This white dot is nothing but the infundibulum of the pituitary gland. So don't miss it. But it's usually, or it should be, anterior to the optic chiasm. Some people would draw the optic chiasm like that, like they do it like that. I don't like this, because it seems that he is like saying, look, the optic chiasm is supracellular, I'm drawing the area in the cellular region, or doing it like that. This is not correct. This is the anterior cerebral artery. So please don't do that. This is the anterior cerebral artery. And if you are not using contrast, it's easily to be mistaken, by the way. So it will be very easy to say that this is the optic chiasm and I'm drawing it like that. So please don't do this mistake. This is the anterior cerebral artery. Remind yourself again and familiarize yourself again. Middle cerebral artery. The middle is the body. Go down anterior to the infundibulum, anterior to the cursor as well, sorry, go down anterior to the cursor, draw the first cut, another one to join the optic nerve. I didn't show you how we join the optic nerve, but I will show it to you now. So if you see the optic nerve is right here, or just to make it poly, go to the sagittal view. Let's see if we are joining it, because if we are not joining it, we have to join them. We have to join both together. And the reason why we have to, because the optimizer can put you some dose there. You don't want the optimizer to put a high dose in an area where you are very keen to... So I can see here something wrong there. As you can see it, maybe I did something wrong there. It shouldn't have any tail above or at the level of the supracellular region. So let's go back and see what's wrong there. Okay, let's put it like that and see what was wrong there. It should be like a straight line, supracellular, directed posterior and upward. Shouldn't have any tails like that. Let's see what we did. Okay, good. Maximize. Let's go up. Okay. Oh, that's what you can see. Because I was showing you that this is wrong, it appeared on the sagittal view in a wrong way. So don't do that, please. Okay. And that's what happened now. So please don't do that. It's not correct. Okay. You understand now what I'm talking about and why it looks like very weird in the sagittal view. In sagittal view, the correct chiasm should be a line. Okay, just one line, and this line is directed posteriorly and upward to join the optic tract, and also it will join the optic nerve. Let's see if we are joining the optic nerve. Okay, as you can see it's very nice. I like that. I mean, based on the anatomy of the CT, I mean, if you can do better definitely with an MRI, but we are talking about CT-based optic chiasm. So you can see it here. So if you see this picture that the optic chiasm is joining the optic nerve at a certain point, I'm happy with that, because the optimizer can never put any dose there, because I will protect the area, and especially if you're putting an PRV of 2 millimeter around it, so we're 100% sure that this area is safe and you don't have to worry. And this is how we draw the optic chiasm on a CT. I hope this is number one. This is a useful trick, and thanks for Frank Lohr. And the second structure I want you to be aware of is what we are calling it the let's say here, this should be axial, this should be maybe coronal, or maybe this is sagittal, and this we make it axial. Okay, the second structure I want you to do is the hypothalamus. Sorry, it's not the hippocampus, I'm talking about the hypothalamus. Are you going to draw the hypothalamus on the CT scan? It seems you are a crazy guy. Yes, I will. Just by knowing the anatomy and taking the advantage, honestly, sorry, I will take the advantage of the simple way the ESTRO guidelines did it, actually. So if you looked at the past when we were trying to localize the hypothalamus, it was really difficult, and you cannot do it unless you do the MRI, because it's simply you're searching for gray matter. So, and you cannot see gray matter on the CT, so you have to have an MRI to draw the hypothalamus on the old days. But today, I think you can do it. So how can we do it? Let's see. I'll do it on the CT, and then we go back and look at the MRI and see if I'm a liar, or I'm telling you something that it can be useful if you think you want to do it. So let's talk about what's the value of drawing the hypothalamus first. Why do we need to draw the hypothalamus? Honestly speaking, you may not be, I mean, we don't have to routinely, and unfortunately I went to one of the largest cancer center in UK, and they were not happy at all of drawing it. I was very frustrated by seeing that, because I felt like, I mean, if you can do it, just do it, okay? You don't have to if you know how to do it, just do it, okay? And you can even collect data. You can say we can do a lot of nice things about with this. The guidelines would tell you something very nice, and I will get for you the guidelines on an MRI to see how we can do the hypothalamus. And then, but before going that, let's see how we can draw the hypothalamus on a CT scan. If you localize what I'm calling it the optic tract, when we talked about the optic tract just now, if you look at the optic tract, you will see in between the limbs of the optic tract there is small beads there. These beads are the mammillary bodies. In the new guidelines, they tell you you can draw the mammillary bodies as part of the hypothalamus, so there is no harm of doing that. The hypothalamus is a group of nuclei, actually. So if you looked at if you ask one of the radiologists to show you what is the hypothalamus, it will tell you it's a region, actually. You cannot localize it because it's a group of nuclei, and together we consider it as the hypothalamus. My landmark for the hypothalamus will be the optic tract, honestly. So this is the optic tract here. In between the optic tract, I will draw a structure, two limbs. Don't take the optic tract, okay? Just draw a structure like two limbs on either side, and I will call this the hypothalamus. I'll show it to you in the MRI, and then you may believe me on doing it, okay? And then the guidelines would say, go to the cut where the anterior commissure of the third ventricle. We all know that this is the third ventricle, yeah? So the third ventricle, when you go up with the third ventricle, you see there is some fibers crossing on each side, and this is nothing but the anterior commissure. The anterior commissure is joining both cerebral hemispheres at the level of the third ventricle. The guidelines would say, go to the anterior commissure and then draw a 3 millimeter thickness structure joining the anterior to the posterior commissure. But I will not do that. What I would do is I will go to the slice below the anterior commissure, and I will start to draw a 3 millimeter thickness structure. It will not allow me to do that. and then I will just evacuate it. So 3 millimeter structure on either side of the optic of the commissure. Don't take the commissure now. Okay, go down below 3 millimeter structure on either side of the commissure. Thickness is 3 millimeter. You can say, but how long posteriorly? I would say it's very arbitrary, because I cannot see the gray matter there. And then, because we did the mammillary body and we did the structure in between the track, all what I have to do now is to interpolate between both and show how it will look like. Okay, yeah, a bit tricky, but believe me, it's not bad. Okay, good. So interpolate the structure. You will end up by structure, when you look at this coronal view, maximize it, you will end up by structure as if that's two limbs just situated on either side, and it's exactly in the region where the hypothalamus should be. Let's look at it. Look at this. This is the hypothalamus, and if you see this limb, two limbs on either side, I would say this is the hypothalamus. And just by knowing anatomy, I can localize. I'll show it to you in the MRI, and you may believe me. But before we go through that, the guidelines also made our life very easy. They just asked us to do something in the axial view. They asked us to go to the anterior commissure and posterior commissure and join them together. So the last cut, when you go to the hypothalamus and you want to draw the hypothalamus, all what you have to do is to go up at the level of the anterior commissure, posterior commissure. It's a bit sometimes tricky to find it in the CT, but you can localize it. Take your time, and you can see something. So I would say there may be here, maybe this cut as well, and then all what you have to do is to join the anterior commissure to the posterior commissure. I would say it looks like this. This is anterior commissure actually, so maybe we have to do that in this slice. Okay, good. Let's see. Trying to localize the anterior commissure with the posterior commissure. Yeah, it seems to be. This looks like the anterior commissure. So the guidelines would say you just have to connect both together. 3 millimeter thickness. This will be 3 millimeter thickness. Make it homogeneous. This will be your upper last cut on the hypothalamus as a structure. Okay, so it's easy. Let's repeat the steps and then go to the MRI and try to do it there. Okay, so localize it in the optic tract. So write down with me and we go to the MRI now. So localize the optic tract. On either side of the optic tract, this is the starting point of the hypothalamus. If you can't see the mammillary bodies, take the mammillary bodies with you. And this is also a very simple thing to do. Take the mammillary bodies with you. And then go up, localize the anterior commissure. Localize the anterior. Don't draw on the anterior commissure. Go to the slice below the anterior commissure. And then draw on either side of the gray matter. I said it's posterior will be arbitrary. I would do it something like maybe 7 millimeter, or if you change the color, try to localize the difference between the white matter and the gray matter on the CT. It's very difficult. I wouldn't do that. But you try to take something like maybe an area of like few 7 millimeter, something like that. Yeah, from here maybe I would stop there, so I wouldn't take more than that. And then at the uppercut, anterior commissure and posterior commissure, join it together. Maybe I'm imagining. Let's see if we can do that on the MRI, and then we can. You may believe me or not. Okay, let's see. Sorry, let's go to the MRI. Hopefully still it's there. Yeah, it's still there. Good. Oops. Okay. Good, still there. Okay, let's go. Let's see the MRI. This is a beautiful MRI. I was trying to draw the hippocampus as well. Let's try the hippocampus as well today. If we can do that. Just let me remove this. Okay, good. So let's see what we were talking about. So first, let's see the chiasm, and then let me magnify this. So let's see the chiasm first, and then we will talk about the hypothalamus. So I was just telling you that the circle of Willis is composed of the anterior cerebral artery and the middle cerebral artery. And here you can see it's an MRI. I mean, yeah, I know my juniors would say, but I think we did a lecture on that and how to differentiate between T1 and T2. But if you want to see anatomy, you have to go to the T1. T1 is white matter is white, the gray matter is gray. But please don't say that in medicine. We have to be very scientific. So you can call it hypo intense or hyper intense or low signal or high signal. So if it's white matter, I would say it's hyper intense or high signal. If it's gray matter, it's low signal or hypodense. I mean, try to use some scientific words. It's gray and white is for me, so for anatomy or between us only. So white is white matter is white in T1, and gray matter is gray in T1. In T2 it will be the inverse. In FLAIR it will be inverse. The white matter will be gray, the gray matter will be white. How did I know that this is a T1? Because the CSF is a signal void or black, if you want to say that. If it will be white, this will be T2. You don't have to go through that. Please refer back to my lecture. You can see here it's with C. C means there is a contrast injected, and you can see easily it is inside the vessels, and it's very, very obvious. Now let's see the chiasm. The chiasm in MRI is beautiful, and nobody would I mean, it's very, very easy to localize the optic chiasm in MRI. You can see it here, and even if it's interrupted like that, but you still can see it. So you can see the optic chiasm, you can see the optic tract here on either side, okay? You can see it clearly, I think. You don't have to worry. This is the optic tract. So it's easy to draw the optic chiasm in an MRI. I think the talent would be to draw it on the CT. Let's see the hypothalamus. What I was telling you is look in between the optic tract. Yeah, this is what we said. Yeah. Yeah. So look in between the optic tract, and I told you something called the mammillary body. Look at this. This is the mammillary body. The guidelines would say you can take the mammillary body. So this is the first step. Take the mammillary body. I'm sorry that, I mean, it just, we don't have tool for drawing here, but I'm just trying to make it simple for you. Okay, good. So let's draw the mammillary body. You can see it clearly. It's very nice, and it's on either side as well. So I try to do it again. Polygon, go there and do it, and draw it. Okay, you can see it like that. Yeah, and go to, this is the first slice. Yeah. Anyway, it stopped working. Go up. Yeah. Sorry. Good. Slowly. Yeah. In between. So in between the optic tract, you can easily delineate the mammillary body, and this will be part of the hypothalamus. Okay. It's very slow. Go. Don't draw it slice by slice. You just go up. Last edited by Mustafa Al-Haddad. Yeah. So we have to delete that, by the way. So don't go slide by slide, but you can easily see it. Yeah. So if let's go up. I try to move it from here. Let's go up and see what's happening now. Okay. I was trying to draw it before. I will remove it for you. Okay. Let's delete. Okay. Good. So draw the first slice in between the optic tract, as we did in this way. Oh, disappeared. Oh. So draw it again here between the slice. I'll do it again. Yeah, let's try to do our best. So mammillary body in between the optic tract. This is part of the hypothalamus. Okay. Do another one. Poly. Go to another one. And as I said, don't try to draw in the next slide. just go up, okay, and search for the third ventricle. So the third ventricle will start to appear here. You can see it clearly, and then the third ventricle will join the anterior commissure will join both cerebral hemisphere together. Let's see. Go up. We will go up now. Okay. Go up. 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 Another cut. Just another cut. Let's try here. Okay. Here we are. Yeah, you can see the anterior commissure here. It's easily seen. This is a white line in between, but don't draw now. Just go one cut below the anterior commissure, okay? Let's see something like that. And try to draw the gray matter you can see. Let's see what we can do here. Okay, so I will draw a 3 mm structure on either side of the lateral ventricle like that. And this is why I would say that in the past we would draw something like that, by the way. So if you looked at the guidelines from the like in the green red journal, we used to do it like something like a triangle shape, but now it's easy. So because they made our life much easier, actually the guideline would say you just have to draw 3 mm structure on either side of the third ventricle. You can see it here. I think the MRI is beautiful and it's very easy to delineate it. Yeah, well, this is all what you have to do. Go to the opposite side and draw another structure of 3 mm thickness. Yeah, and that's why when I was doing it on the CT scan, I didn't know how much posteriorly to go. But if you have an MRI for the same patient, I mean, this is not the same patient, by the way, but if you have an MRI for the same patient, you can see the gray matter and you can adjust it and you can say, okay, so I will go posteriorly something like 7 mm to 8 mm, and you can localize it like that. And then interpolate between the slides. This will end up by giving you the two structures in the coronal view. And then when you go to the level of the anterior commissure slice, as we said, the guidelines is true. And honestly, we didn't do that in the past at all. But now the guidelines will tell us that all what you have to do is whenever you see the anterior commissure, join the anterior commissure with the posterior commissure in a 3 mm thickness slice, and this will be your hypothalamus on either side. So the same will do it on the other side, and this will be the last cut of the hypothalamus. I hope this is easy. Just to show you again, so what you have to do, go in between the optic tract, please draw the structure in between. If you see the mammillary body, you draw it. Then go to the anterior commissure, go to the cut below the anterior commissure, draw on either side 3 mm structure. It's actually dealing with the gray matter there, or the nuclei you can see there. Just interpolate. This is the limbs of the hypothalamus, and the last slice of the hypothalamus is nothing but connecting the anterior commissure with the posterior commissure, and this is how the guidelines will tell us about how to draw the hypothalamus. I hope this is useful for you. Yeah, it's not very difficult, but if you are interested in the hypothalamus, before you go out of the packs, by the way, you have to remove the structure, otherwise it will stay and it will be very confusing why this guy is doing that. So we need to make sure that there is no structures left. Yeah, we have to remove it, otherwise it will be saved. By the way, you cannot anyone who's like doing a report or something, it will remain there. So please make sure that after doing a few annotation or a few things on the MRI, you just have to clean it up, make sure of that. Okay, so this is the optic tract. This is the hypothalamus on either side. This is the third ventricle. Anterior commissure is easy to see, and I don't think something will be much easier than that. And I hope this is useful for you. Okay, the other structures we have to go for, I think, if you're talking about the hypothalamus, then you have to talk about the pituitary, and the pituitary is very simple. We sometimes we cannot see the pituitary in the CT scan, and the nice thing that the the nice thing that the guidelines would say, you just take the cell as a surrogate in 2 slides, and that's it. So if you can see it, it will have the same density as the brain. If you cannot see it, then you just have to take the cell as a surrogate, and you have to draw it till you see the infundibulum. You don't have to draw the infundibulum unless sometime you can say, so this can be the pituitary. If you go up and see the infundibulum, so you know that the cell is done. And if you go to the supracisternal supracellular cistern, definitely there is no pituitary there. So this is a pituitary stalk. It may be interesting to say that irradiating the area of the circle of Willis may end up by a syndrome called the Moya-Moya syndrome. I don't know if you heard about it. So Moya-Moya is a syndrome where the kids, when we irradiated these young kids, you can see it. The Moya-Moya in Arabic language, for those who are working in Saudi Arabia, they will understand me that Moya-Moya means water. So if you remember the syndrome by the Arabic word Moya-Moya, water, then you may remember that irradiating the circle of Willis can end up by a Moya-Moya syndrome. Moya-Moya is a Japanese word, so it means, if I remember correctly, it means how do you say that? A puff of fume. Yeah. So when you like smoke a pipe or you smoke a cigarette and you push the fume out, you see the fumes will form what we call a puff of fumes. Yeah. So the shape of the fumes or the puff of fumes means moya moya. So the Japanese described a syndrome called moya moya syndrome, which is some changes happening around the area of the circle of Willis. They found it in kids with some kind of insufficiency of the circle of Willis. When they have insufficiency of the circle of Willis, a lot of collaterals will start to appear, and the anastomosis of the vessels will appear in the angiogram as if it's a puff of fumes, and that's why they call it moya moya. If we irradiate the circle of Willis, sometimes it happens that we can see kids with the moya moya syndrome. And maybe it's too much for if you don't want to know, just I mean, yeah, sometimes I feel like funny things can make me remember important stuff. But yeah, I would say that the hypothalamus would be very important in kids. So if you are dealing with kids, please and try to localize the hypothalamus, because it's important. We know that pituitary failure may be coming from the hypothalamus, and the theory would say that maybe the pituitary has a high tolerance, but the hypothalamus doesn't have the same tolerance in kids. And I think one of the factors why we reduced our dose from like 18 gray to 12 gray in whole brain radiotherapy for acute lymphocytic, for acute lymphoblastic leukemia kids, the children, when we it's a long time ago now, most of the protocol is off cranial prophylaxis, but we moved from the cranial prophylaxis from 18 gray to 12 gray. One of the theories would say that we are reducing the risk of having or for pituitary failure, because the hypothalamus tolerance should stay within the 12 gray. It will be interesting if you want to do more research on that. I think there is still a room for a lot of research on the hypothalamus. I know we spend a lot of time saying very strange things, but you can still skip it if you're not interested in what I'm saying. But I hope my junior will find it a step forward for them to start drawing risk structures. I think the third risk structure we need to familiarize ourselves nowadays are the pharyngeal muscles. The importance of the pharyngeal muscles, I think, will come very soon, and we will have to try. I'm talking to myself, by the way. We have to try to familiarize ourselves with the pharyngeal muscles, because of the new results of the DARS trial, DARS, DARS trial. So Professor Chris Nutting from the Marsden, this year in 2020, he gave an oral abstract for the first results of the DARS trial, which are basically trials talking about sparing the pharyngeal muscles or muscles uh, involved in trismus and difficulties in swallowing. So if you can spare the pharyngeal muscles, this may help the patients to have to reduce the problems from any kind of swallowing problems in the future, less aspiration. And we all know that one of the problems we are facing for our patient is aspiration in the long term when they are cured from cancer, but their swallowing function is not that good. So the DARS trial was looking at that, reducing the dose to the pharyngeal muscles may help to reduce the incidence of swallowing problems. And the initial results seems to be very promising. We need to see it as a full paper still. We need to make sure that the local recurrence and it's within the acceptable range. So I think we need to familiarize ourselves with the pharyngeal muscles. So how do we draw the pharyngeal muscle in a very simple way? Again, guidelines are different and it's there. So if you want to just stick to the guidelines, you don't have to stay with me. If you want to see how I'm trying to simplify it for myself, then you can still continue. So the pharyngeal muscles, there is several guidelines, honestly, telling us how to draw it. And I feel like the easiest way is to draw it as one structure. This is number one. You can separate it into superior, middle, and inferior, and I can tell you how to do that if you want. But I would say that it's sometimes very difficult to separate the superior from the middle because the middle pharyngeal muscle is overlapping actually with the superior and the inferior pharyngeal muscle. So if you end up by saying, okay, I will just draw a small piece of tissue and they'll call it middle pharyngeal, it's up to you. You don't have to worry about that. So how do we draw the pharyngeal muscles? I would just put it now, pharyngeal. Okay, good. And change the brush to 2 millimeter. If you have a smart planning system, it will help you, but my planning system will not help me on that. I will show you what will happen. And then we will start to draw the familial muscle. Write down this first step. The superior constrictor muscle of the pharynx, superior constrictor muscle of the pharynx, start at the sphenoid humulus. The superior constricted muscle of the pharynx will start at the sphenoid humulus, okay, and will end at around the second cervical vertebrae. Again, the superior constrictor with S, sphenoid humulus, second cervical vertebrae. Let's translate that. What I'm saying is the superior constrictor muscle will start at the humulus of the sphenoid. We know something called the pterygoid plate. So we know the pterygoid plate, we know the pterygoid fossa, but maybe we didn't know, at least me, that the lowest part of the pterygoid plate, this tiny bone here, is called the humulus of the pterygoid plate. So the end piece of bone here is called the humulus. And we all know that the pterygoid plate it's part of the sphenoid bone, and that's why I'm using the word sphenoid bone humulus, okay? So that's why I'm just trying to make it simple for me at least. So the humulus of the sphenoid bone will be the starting point for the pharyngeal muscle, okay? So you can localize like this step, or if you want to take it from here, depends on the slice, by the way. Now, what we have to do is to join a structure from the humulus on the lateral wall of the pharynx, 2 millimeter thickness. And why 2 millimeter thickness? Because it's a very thin muscle. Down to the prevertebral muscles. And then you have to go lateral, okay, just lateral to the prevertebral, just anterior to the prevertebral muscles, and then go again upward, which is a U-shaped structure. Oh, this is my planning system, sorry. Your planning system will not do that. So do it again. So So 2 millimeter structure, vertical line, 2 millimeter vertical line down to the prevertebral muscles. So this is a prevertebral muscle disease, and you have to familiarize yourself with that. Again, then a U shape, and the lateral limb will go through the pharyngeal wall, and then another upward limb 2 millimeter in thickness, and this will be the first cut. Oh, I'm sorry, the first cut of your superior constrictor muscle. Remember with me, sphenoid hamulus. I'm saying it with a way you'd never forget it. Sphenoid hamulus, second cervical vertebrae. What does it mean, second cervical vertebrae? Then you have to draw it down to the second cervical vertebrae. But I'll tell you something very interesting. The superior constrictor muscle will first be a U-shaped. Again, this is not science, guys. This is just for between us, okay? When it comes to the science, you have to say it in a scientific way, okay? So we're talking about the superior pharyngeal muscle. Superior pharyngeal muscle, we will start from the hamulus of the sphenoid bone, and we are drawing a 2 millimeter structure in front of the pharyngeal mucosa. The pharyngeal mucosa will be involved. It's unavoidable. You cannot say this is a pharyngeal mucosa and this is a pharyngeal muscles. I mean, nobody would do that because it's very, very, very thin. But you wouldn't take the prevertebral muscles. So you don't take the prevertebral muscle. It's just 2 millimeter thickness, okay? U shape, it's for us, okay? So the upper part of the superior pharyngeal muscle, it will be U-shaped. When you go down, you will see that it will start to be V-shaped. Look what will happen, okay? Let's focus on this side, okay? So the starting point was very important for me because it's U-shaped, it's easy to detect, it's easy to draw. That's it. It's very simple. Don't draw next slice, okay? Just go down. What will happen is the pharyngeal wall will start to be V-shaped. So can you see this wall here? So look at this. What's happening now? Look, look. So the pharyngeal wall started to be a V shape. Yeah, can you see that? Again, we are not drawing the, oh, sorry for that. Yeah, this is my planning system again. So 2 millimeter thickness, if your planning system can help you and stay 2 millimeter thickness, you will take the mucosa. No way you can separate the muscle from the mucosa. This is a train. So in no way you go for the muscle, the mucosa, you separate the mucosa and the muscle, and it will be a V shape. And the anterior wall of the pharyngeal muscles will be nothing but the structure in front of you. What does it mean? So this is the hamulus, yeah? When you go down, you'll see that the tongue will start to appear, yeah? So it's just very easy to delineate. I mean, we don't have to go to the tongue. So this is the anterior wall, so that the tongue will be part of the anterior wall. And when you go down more and more, you see the hyoid bone as well. So this will be your anterior border again. Please stick to 2 millimeter. I'm sorry for that. Okay, good. When you look at the MRI, and maybe we can go to the MRI now and try to localize the pharyngeal muscles on the MRI, because the MRI is very nice. You will see that in the midline there is no muscle actually. That's why it's very thin. You can see here there is no muscles there. So if on either side it's thick, but we have to make it continuous. But honestly, there is no muscle in the middle. Actually, in this area, in this exactly where it looks like, if you looked carefully, you see the density is different. This is the raphe. This is a tendon where the the pharyngeal muscle will join together from the skull base down to the neck. So there is no muscles in the midline there because it's just a tendon or a raphe on both sides, or both sides are joining together. So first go to the hamulus. It's U-shape. It will continue to be U-shape, and then it will be a V-shape. So you can see it easily. If I want to draw it, sorry for my planning system again. Really sorry for that. But this is a smart planning system. Okay. Good. There is another trick here. So when you go down easily. Sorry, 2 millimeter thickness along the lateral wall of the pharynx. Don't take the prevertebral muscles. Take the mucosa. Midline is raphe. That's it. When you go down, you will see something very interesting. You will see that the superior pharyngeal muscles, some of the guidelines will do it like that, and I want you just to share it with you. So some of the guidelines will do it something like that. So you join to the pharyngeal muscle up to the anterior mandible, And the reason is, and this is very important trick in oropharynx, we will do it. When we come to the oropharynx and the retropharyngeal extension, we'll tell you this trick. It seems that it's a very interesting trick. So when you go to the, if you see this, some guidelines doing that, honestly, you can do it, but you have to understand 2 points. The first point, that the pharyngeal muscle will never extend there. It is attached to a tendon here called the pterygomandibular raphe. So there is a tendon here where the pharyngeal muscle is attached, called the pterygomandibular raphe. And this is a tendon that you cannot see in CT. You can see it in the MRI. But if you do it like that, this means that you are extending the pharyngeal muscle plus the raphe. So if you want to follow the guidelines saying that you have to take the raphe, just do it. But you understand now that it's not, the pharyngeal muscle will not go there. It's attached to the tendon, and the tendon is attached to the mandible. Okay, so this is a very important trick. Then when you go more and more down, we said that you go down the pharyngeal muscle on either side, it will start to be a plate shape. It will be something like that, because there is nothing, you cannot see something extending after the mandible. When the mandible starts to disappear and the joint, this raphe this lateral pharyngeal extension will disappear, and the muscle will be just as if it's a plate shape. Okay, so whenever you go down to the oral cavity, the pharyngeal muscle will start to be plate shape, something like that, and will be even a shorter plate, because it will be just on either side of the tongue and the hyoid bone when you go more and more down. And then you continue drawing this plate shape. Okay, you don't have to go down, because we said the mandible end completed, there is no mandible anymore, so it's just plate shape, and until you reach the level of the tongue on either side of the tongue. So this will be again pharyngeal muscles. Okay, I hope it's not too bad. Yeah, you go down, and you can see here, so in front of the tongue, either side is the tongue, because it has an attachment on the tongue. We all know that. Yeah. So it's like a plate shape. Yeah, just think. Okay, sorry. Okay, and then the hyoid bone will come. You can see the hyoid bone here, and usually with the upper border of the hyoid bone, you end up your pharyngeal muscle. There's no more superior pharyngeal muscle, sorry. And then we'll start the middle pharyngeal muscle. The middle pharyngeal muscle is a very small piece of tissue between, let's see if we are at the level of C2, cervical spine 2, by the way. Let's go to the sagittal view. Let's see if we are correct or we are doing something wrong. Okay. As I said, I'm trying to simplify things as much as I can, but you maybe you are not very satisfied with that. Just use the MRI then in doing it. It will be there. You can see it, and it's very easy to localize. Okay. So because we draw it in the superior middle altogether, when you come to C2, you can then stop and say, look, I will stop at the superior pharyngeal muscle here, and then I will start drawing the middle pharyngeal muscle. But honestly speaking, it's very difficult sometimes to differentiate between the middle and the superior pharyngeal muscle. And that's why I would prefer, I would say, just do it continuously, and that's it. And I think the SORO guidelines told us, just for simplicity, draw it, and for practicability as well, just draw it as one piece. Some people will take the hyoid bone as a landmark. I wouldn't do that, because the position of the head is different, honestly. But for anatomy, you may be interested to know that the pharyngeal muscle will end at the superior border of the hyoid bone, and the middle pharyngeal muscles will start from the superior border of the hyoid bone and can end by the inferior border of the hyoid bone. And then you can overlap between both. That's why it's very difficult to delineate the pharyngeal muscle separately. Oops, sorry for that. I have to reconnect. So So I would say that it's easy to delineate the pharyngeal muscle. It's not difficult at all. You have just to familiarize yourself with few anatomical landmarks, and then you can easily do it. The middle pharyngeal muscle, you can stop at the inferior border of the hypopharynx, and as I said, we still can do it continuously. I don't know why my internet connection is not as good as it was before. Okay. And you go down, you can see the pharyngeal muscle on either side of the tongue. Plate shape if you want to stick to that. If you don't, you can see the base of the tongue is coming, so it will be like a narrower, a smaller part will be the pharyngeal muscle. And you go down till the cervical vertebrae C3 if you want. If you want to take the anatomy, then the hyoid bone, the lower border of the hyoid bone, is the end of the middle pharyngeal muscles, and the middle pharyngeal muscles will also end at what we are calling the lower border of the arytenoid, or the upper border of the cricoid. In this region, the pharyngeal muscles are very easy, honestly, to delineate because it's marked in between the thyroid cartilage, and in practice, or in reality, we are talking about two different. So it's easy to delineate it because you can see it's just in between the thyroid cartilage. You don't have to extend beyond, and so it's easy to say that this is the pharyngeal muscles, and it's easy to delineate it, honestly, at the level of the larynx. It's very easy. And the nice thing maybe to understand that the pharyngeal, the inferior pharyngeal constrictor muscle of the pharynx can be divided into thyropharyngeal, which is the part of the pharyngeal muscles just at the level of the larynx. So some would do it like that and call it superior thyropharyngeal muscles, and they continue to draw till the cricoid cartilage started to appear. When the cricoid cartilage start to appear, they will call the muscle now as a cricopharyngeal muscle, and the cricopharyngeal muscles are the thickest part of the pharyngeal muscles, and you just have to draw in between. It's thick, you can see it, yeah, in between the cartilage. It's very easy and very simple. And you'll see that it will start to be the esophagus, and it will, if you go down, I just want to waste your time more than that, and you see then the esophagus will start to be circle, and then the esophagus will continue as usual, as we all know, that the circular muscle of the esophagus. If I interpolate this all, you can easily see that it's one continuous structure. I think this is the easiest way to do it. You don't have to separate, but if you are interested in more anatomy, let me review it with you, and then we can decide where to go. Okay, so it's one. I think it is some thickening. It's not very. So it's one structure from above downwards. So superior constricted may end up by C2, middle constrictor pharyngeal, you can up to C3, but honestly, as we said, there is an overlap between the middle and the superior, between the middle and the inferior, and that's why some people would just draw it like that. The inferior constrictor, as I said, you can start it at C3 or just as continuity, and some people would start it at the lower border of the hyoid bone, and that's why the difference between the guidelines will make us very confused. So some would start the inferior constricted at the hyoid, but honestly, if the position of the head is different, I think it will be very, very low. So I wouldn't. It's just a suggestion from my side. I'm not the expert to tell you that, but I would do it as one structure: superior constrictor, C2, sphenoid humulus, C2, second cervical vertebra. Start to be first U shape, V shape, and then plate shape. And then the inferior constrictor can be divided into two muscles if you want: thyropharyngeal muscle, which will start from the lower border of the hyoid bone, going down to the cricoid or the lower border of the arytenoid. We all know that the arytenoid is lying on the cricoid, so I don't know if you want just to complicate things, just say the inferior border of the arytenoid. But if you remember when we talked about the larynx previously, I told you that the arytenoid has the cord tubercle, and it acts as a joint on the cricoid by which we are talking and speaking and changing the vocal cord vessels. Then the pharyngeal muscles will end at the level of the cricoid. From the cricoid down to the esophagus, you can call it the cricopharyngeal muscle. If you are not happy, you just do it as one piece, and this is what the S2 guidelines in head and neck cancer would tell us to do, so you don't have to worry about it if you want to do it. But I would start to familiarize myself by the pharyngeal muscles nowadays, because it's coming very, very soon that we may need to do it after the DARS trial. I think it's too much for you today. Don't forget the pterygomandibular raphe. The parotid gland is very, very easy. Just maybe the guidelines would say that if you are not using contrast, don't forget to take the retropharyngeal vein inside the parotid. But I don't think that the problem would be in the parotid. I would say we all are happy with the parotid gland. What else do you have to know? There is other structures involved in swallowing. So they now have they put the genioglossus muscle, they put the hyoglossus muscles, but I think this would be too much for you to draw. And as I said, you can now, with the new technology for the auto segmentation, you can also teach your planning system to do it for you. So the planning system can do it, and then you can correct, and the planning system will learn how to do it from you. So if you correct it by the time, I think the race station can do that. I think the pinnacle can also do that. And I think this will cover the risk structure. One structure that we didn't talk about in the brain, which is the MRI. If you have still some effort, I can go to the MRI and show you the hippocampus, because the hippocampus is also very important in brain. And if you're dealing with brain patients, I think it will be useful to know how to draw the hippocampus. And the last structure we can do today is the brachial plexus. Oh, we forgot the brachial plexus. Oh, that's more than 1 hour now. I don't know if we can upload all this together. Let's do the hippocampus together quickly, and then we can go for the brachial plexus also quickly. So the hippocampus is very difficult to draw on the CT, so I didn't try to draw it in the CT because it's basically gray matter. You have to localize gray matter, so you cannot see the gray matter in the MRI. Sorry, the CT. You have to do it in an MRI. So that's why you can practice on the MRI, and you have to put it in your planning system so that you can know how to do it. So when you go to the MRI, again, this is a T1 MRI, and this is, by the way, this is the central sulcus. You can see the inverted omega shaped central sulcus, and this will be the precentral gyrus, where the motor area is located. Postcentral gyrus is a very important landmark in brain. And this is the largest sulcus that's very close to the midline, so you have to familiarize yourself with this if you are doing brain tumor. The central sulcus is very important. Omega sign of central sulcus is the motor area for the brain, and nobody can touch this region, by the way, if any tumor lying there. So I just want to look at this. This is the lateral ventricle. We all know that this is the lateral ventricle. The lateral ventricle has a component when you go down. And so if you move your cursor down, so go up and go to the largest part of the lateral ventricle. When you go down to the lateral ventricle has of what we are calling it the lateral horn of the temporal lobe, or the temporal horn of the lateral ventricle. So the lateral ventricle has part of it is very close to the temporal lobe. You can see here the temporal lobe. I don't think that we don't know the temporal lobe. We all know the temporal lobe. Is it? Yeah, I think, yeah. I'm sorry. Yeah. just to make sure, yeah, that we all know the temporal lobe. Yeah. So if you look at the sagittal view, and this is the temporal lobe. Yeah. So if you look at the lateral ventricle, you can see the lateral ventricle has what we are calling it the lateral horn, or the temporal horn of the lateral ventricle. If you look at the floor of the lateral ventricle, the floor of the temporal horn of the lateral ventricle, you will see this gray matter here. This is the hippocampus. So the best view to see your hippocampus is just the floor of the lateral ventricle. So you have to familiarize yourself with this. Go to the lateral ventricle, the temporal horn, and then look at the gray matter in the floor. So there is no gray matter here. You can see the white matter. Again, we'll see the white matter or the gray matter in T1, whether it's T1 with contrast or T1 with, don't please confuse and go to T2, because the white will be gray and the gray will be white. Okay, so T1 where the gray matter is white, the white matter is white and the gray matter is gray, or hypodense and hypo. So I will not repeat that. So you can see here there is something, the gray matter inside the floor of the floor of the lateral ventricle. This is the hippocampus. Some of the planning system will allow you to draw on the sagittal view, so please do it. And I think for me it's very, very easy, and I prefer to draw it on the sagittal view. But I would give you this trick, please. When you draw it on the lateral view, if your planning system will allow you to do that, don't be very generous anteriorly, because the hippocampus will fuse with what we are calling it the amygdala. So please keep your eye on the axial view as well. So don't miss this. So keep your eye on the axial view. Why I want you to keep your eye on the axial view? Because please write this down, any gray matter anterior to the lateral horn or the lateral ventricle temporal horn, this is not part of the hippocampus. This will be the amygdala. So we don't draw the amygdala. So if you, for example, on the sagittal view, you find your structure coming, and then you find the structure coming anterior to. So looks, this is the end of. Let me increase it in size. I don't know why I'm doing that. Just a second. Okay, so if you start to extend your hippocampus anterior to the lateral ventricle, this is the amygdala, then you can remove it. So stick to the gray matter on the, so if you're talking about the axial view, we are talking medial, but if you're talking about the sagittal view, I would call it in the floor of the temporal horn of the lateral ventricle. You can see it here. You just stick to this, and then you'll see that this is started to be the tail of the hippocampus. The hippocampus will reach the area where the splenium is located, and then it will end there. I'm sorry, just a second. It's slow. Okay. Good. So here you can see it. He is going to very close to the splenium. Oops. Some people would do it the opposite, so go to the posterior horn and then track it. But I usually go to the temporal horn first, make the biggest part of it, and then the tail will go inside. I don't. Sorry for the connection. So you just end the tail without any problem there, and you don't have to take beyond that regions. But you can see that the hippocampus is the gray matter anterior, not anterior to the lateral horn. Okay, so don't go beyond the end of the so this should be inside or medial to the lateral ventricle. I hope this is not difficult. You can see it here. This is a tail. I don't know why it's very slow like that. Sorry for that. I think what I can do is to cancel the M mode. Just a second. Maybe that's why. So if we cancel, how can we cancel the M mode? Yeah. I don't know how can we cancel that. Why it's so slow? Just a second. Okay, and so familiarize your eye with the lateral horn, and then any gray matter inside will be, this will be the hippocampus, and you just follow the hippocampus, gray here, gray there, just draw it, and you will end up a very nice looking structure, the hippocampus. And also if you looked at it in the sagittal view, you'll see that it has a body, has a head, and has a tail. And if you extended your structure anterior to the lateral ventricle, then you know that you are talking about the amygdala, and we don't take the amygdala into consideration, please. So be careful with that. So we just don't take the amygdala. So for example, this area, this will be part of it, of the amygdala. So we don't take the amygdala into consideration. As some call it, the moon sign coronal section. I think if you want to look at it, it's beautifully beautiful, the hippocampus in the, oops. So again, in the temporal lobe, you go to the temporal lobe and you look at the, this is posterior, so we want a bit, yeah, so this is the temporal lobe. You can see the temporal lobe here, yeah. Okay, and then we move on to search for the, sorry, you know, not the best to do that, but you can see it here. Just a second. Yeah, you can see something in the gray matter on the floor of the lateral ventricle temporal horn, and this will be your hippocampus. And if you go anterior, this will be the amygdala. Where is the amygdala now? You know, the arrangement. Yeah, I think we are now anterior in the amygdala now. Yeah, it's correct. So any gray matter anterior to the temporal lobe, this will be the amygdala. You don't have to take it into consideration. Okay. So just draw on the floor of the lateral ventricle. I hope this will be useful for the floor of the lateral ventricle. Okay. This is easy, and the easiest way, as I just mentioned, is to look at the sagittal view with the axial view, and you try to localize it properly like that. So if you look at the sagittal view here, the temporal lobe, so we are in the temporal lobe here. Okay, let's lateral ventricle horn. Okay, look at the sagittal view with me. We are looking at it now. So it starts to appear. Let's magnify this a bit. Okay, the ventricle started to appear. I'm learning with you. Here we are. So the gray matter started to, here we are, the gray matter started to appear. So all I had to do is to bring this down there. Okay, so you can bring the gray matter in the sagittal view here, so you can see that this will be the hippocampus, and you draw it here, you see it there, and if it ends, you have to be very careful with the floor, with anterior to it. Don't draw anterior to it. So for example, if I go anterior here, so now we're still there. If we found gray matter beyond that, this will be the amygdala, and we don't have to take it into consideration. So be careful with the amygdala, don't include it, just stick to the hippocampus in the floor, and this is the head, this is the tail, and stick to the hippocampus in the floor of the horn, of the lateral horn of the temporal lobe. I think this is very, very obvious here in the sagittal view. You can see it beautifully located. Just familiarize yourself with the lateral ventricle horn, and then just follow the gray matter. It's not difficult at all. The RTOG also guidelines is very, very clear. I don't have to maybe spend more time. Though sometimes I get confused with amygdala tail still, but you have to familiarize yourself with this area as I'm doing now. We are all learning together, so this is where we are. Okay, so this is... If you allow me, I need to stop now because it's a bit more than 1 hour. I think it's one and a half hour. I don't think you will tolerate more than that. We'll carry on later on, maybe in a week or two. Please forgive me if I did something or I said something wrong. Make sure to read your book, your guidelines. And if you have any comment, please let me know in the comment below. I hope that this is a useful lecture, and till we meet again, enjoy your time. Let's say thank you.